Welcome back. This section is about arrhythmias, but to diagnose an arrhythmia, you need to compare it to a normal ECG. And so, before we can launch into our discussion of arrhythmias, we have to thoroughly understand sinus rhythm. So let's consider that right now. The flash shown in this diagram defines the point of origin of the electrical impulse in this rhythm and in all the remaining diagrams that you're going to see. And this red flash is the location of the sinoatrial node. It has a resting potential of minus 55 to 65 millivolts. Its phase 4 depolarization rate takes it from a baseline value of minus 65 millivolts to the threshold value, which is approximately minus 45 millivolts. Now for sinus rhythm, let's make a distinction between the intrinsic rate of the sinoatrial node depolarizations, which is quite high, but what we actually see in a patient in health is the resting rate, which is the effect of the parasympathetic nervous system slowing down the intrinsic rate from about 110 down to about 72 beats per minute, which is the resting rate. So let's state the obvious. Sinus rhythm is not, of course, an arrhythmia. Here's a typical sinoatrial node action potential. In health, parasympathetic tone is continuously present at rest, and it hyperpolarizes the sinoatrial node action potential such that its baseline is more negative at approximately minus 75 millivolts instead of minus 65. The diastolic membrane potential drifts in a less negative direction at a constant rate of phase 4 depolarization. That is, the gradient of this line remains constant, so the initial hyperpolarization means that a longer interval must pass before the threshold level of minus 45 millivolts is reached. Therefore, with a normal physiological degree of vagal tone, the heart rate must slow down. It takes longer to hit threshold. So normal sinus rhythm has a resting heart rate of about 72 beats per minute. So you must appreciate that this sinus rhythm at 72 beats per minute is due to tonic vagal activity. If the parasympathetic and sympathetic nervous system influences are antagonized with generous doses of atropine and beta blockers together, then the intrinsic or natural rate of the sinoatrial node at 110 beats per minute is seen. Now, let's talk about sinus arrhythmia. So now you are familiar with the effect of vagal tone on heart rate. Now, sinus arrhythmia is sinus rhythm with the now familiar changes in vagal tone superimposed. The degree of vagal tone is cyclical, and this cyclical waxing and waning is related to the function of the respiratory system. These changes in vagal tone occur in response to changes in ventricular filling with the respiratory cycle. In inspiration, the increased negative intrathoracic pressure causes an increase in the volume of the pulmonary vessels. Blood accumulates in these vessels and left ventricular filling decreases. Decreased filling causes decreased stroke volume. This leads to decreased cardiac output and ultimately to decreased blood pressure. This is a negative Frank-Starling sequence. A decrease in blood pressure activates the baroreceptor reflex, which initiates a compensatory increase in heart rate. So you must remember this. There is a compensatory increase in heart rate in inspiration, and heart rate then slows in expiration. The mechanism of sinus arrhythmia is as follows. The baroreceptors inhibit the parasympathetic tone and the electrophysiological effects on phase 4 pacemaker cells of the sinoatrial node, as we discussed earlier. It is the baroreceptors inhibiting a vagal inhibition on the heart, leading to an inspiratory increase in heart rate. Sinus arrhythmia is a normal finding in the young in whom vagal tone is high, so the effect of baroreceptor inhibition is more pronounced in the young. So remember, sinus arrhythmia is completely normal. However, when we see extreme sinus arrhythmias, these may suggest that there is underlying pathology. Now let's talk about sinus tachycardia. Definition of sinus tachycardia is a sinus rhythm at a rate greater than 100 beats per minute. In the majority of cases, sinus tachycardia is an appropriate response secondary to another cause. When trying to identify the cause of any cardiovascular abnormality, we can frequently approach it this way. The cause may be either systemic or local. By this, I mean that the cause is either outside the cardiovascular system, that is systemic, such as pain, anxiety, fever, or a side effect of a drug. Or it can be local, that is within the cardiovascular system, such as a response to a low stroke volume or a low cardiac output and or a low blood pressure. The mechanism of sinus tachycardia is usually triphasic. As we saw earlier, baroreceptors can inhibit parasympathetic innervation of the heart, and they are not the only mechanism which can do so. When exercise requires an increase in heart rate, the initial increase is due to the cardioaccelerator center, which is a component of the cardiovascular center in the brainstem, causing inhibition of the parasympathetic nerves to the sinoatrial node. This parasympathetic withdrawal increases heart rate initially from about 72 beats, the resting level, to 110, the intrinsic level. So inhibition of parasympathetic inhibition allows the appearance of the intrinsic sinoatrial rate. From 110 beats per minute and above, further tachycardia is driven by sympathetic activation of the peripheral sympathetic nervous system, that is the cardioaccelerator nerves arising from the intermediolateral horn at thoracic levels T1 to T4, whose postganglionic fibers directly innervate the sinoatrial node. At even higher levels of exercise, adrenal medullary epinephrine release increases the heart rate further until it reaches a maximum of what is normal for an adult male of 220 minus age for adult males and 210 minus age for adult females. Occasionally, sinus tachycardia may be a manifestation of a primary electrophysiological disorder, for example, tachycardia bradycardia syndrome or sick sinus syndrome. So here is a list of causes of tachycardia unique to the threats we see in the intensive care unit or in the operating room. Now let's discuss sinus bradycardia. The definition of sinus bradycardia is sinus rhythm at a rate of less than 60 beats per minute. In the majority of cases, sinus bradycardia is an appropriate response secondary to another cause. Again, we define the causes as systemic or local, either systemic outside the cardiovascular system, such as pain, anxiety, intense emotional reactions. All these can cause bradycardia. A vasovagal response is a good example, or bradycardia can be due to a beta blocker or a calcium channel blocker. The cause may be within the cardiovascular system, such as a baroreceptor response to severe systemic hypertension, or even a response to intracranial hypertension. As already emphasized, the mechanism of sinus bradycardia is often parasympathetic activation-induced hyperpolarization of the sinoatrial node resting potential. Occasionally, sinus bradycardia is, of course, a manifestation of a primary electrophysiological disorder. Again, tachycardia, bradycardia syndrome may be the cause. There are causes of bradycardia other than sinus bradycardia, and these will be considered in the appropriate section. Here's a list of causes of bradycardia, again, pretty much unique to the threats that we find in the ICU and the operating room. Shortly, we will consider the clinically common arrhythmias, but we will pay special attention to the life-threatening arrhythmias in the context of their recommended ACLS treatment algorithms. ACLS is Advanced Cardiac Life Support, and the ACLS arrhythmias are ventricular tachycardia, including torsade de pointes, ventricular fibrillation, asystole, and something we call pulseless electrical activity, or PEA. Let's deal with asystole and PEA now, because neither of these are true arrhythmias, and we can dispense with them quickly, but let's not minimize them. They're massively important in clinical medicine. Initial resuscitation of asystole and PEA follows the same algorithm. Now, PEA, pulseless electrical activity, refers to a heart rhythm or an arrhythmia that typically can generate a pulse. That is, they are output rhythms. We need to make a distinction here. An output rhythm as opposed to an arrest rhythm. But in PEA, the rhythm is not generating a pulse. The rhythm should be able to generate a pulse, but it is not. Most episodes of PEA occur with sinus tachycardia, so there's no arrhythmia to treat. We don't treat PEA with antiarrhythmic drugs. This rhythm is usually perfectly capable of generating an output, so it is an output rhythm. But in PEA, the ventricle cannot mechanically generate a stroke volume, either because the ventricle is empty due to obstruction of blood flow into the ventricle, such as occurs in tension pneumothorax or tight pericardial effusion or pulmonary embolus. So this is termed obstructive shock. Or the problem could be a biochemical or electrolyte abnormality which interferes with the ability of the cardiac myocytes to contract, and we call this electromechanical dissociation. And this was the old name for PEA, electromechanical dissociation. Now, moving on, asystole is similar. There's no arrhythmia to treat. There is the total absence of cardiac electricity, and there's no cardiac mechanical activity because there's no electrical depolarization. So again, there is no arrhythmia to treat, but this is a terribly lethal condition, and we have to act aggressively and quickly to get the patient out of asystole. The treatment rationale for asystole is to keep the patient alive until you can get them into ventricular fibrillation. If you can get them into ventricular fibrillation, then you have an arrhythmia which you can shock. First priority is keeping them alive with really incredibly high quality chest compressions. In asystole, there is no fibrillation, so defibrillation has no place here. Never shock asystole. Our second priority is to use very high quality chest compressions to generate the best myocardial blood flow and cerebral blood flow that you can get. And if we can get enough blood flow to the myocardium, we may get the patient into ventricular fibrillation. They may spontaneously revert from asystole to ventricular fibrillation, and we can do this with epinephrine intravenously. And then the third priority is to treat VF as per its algorithm and to shock it ASAP. Now, of course, all this will make much more sense once you are immersed in the subsequent arrhythmia presentations and once you've read the ACLS manual. But for the moment, this is enough information so you have the fundamentals for when it comes to studying ACLS. This is resuscitation medicine, and it is a very, very exciting and rapidly changing area of medical practice. We will continue this very exciting discussion on the management of serious arrhythmias in the next video. Thank you for watching. Welcome back. This will be an introduction to arrhythmias. Now, there are lots of arrhythmias, and so the best way to approach this is to divide them into different groups. So we are going to talk about the physiological basis for the arrhythmias. This is a big undertaking, so let's divide and conquer. Let's divide these arrhythmias into smaller groups. There are four main etiological groups of arrhythmias. First, the escape rhythms, then the accelerated automaticity or ectopic beats, the conducting blocks, and finally the reentrant arrhythmias. So let's talk about the escape rhythms. The hierarchy of natural cardiac pacemakers is shown here. The sinoatrial node is richly innervated by both the parasympathetic nervous system and the sympathetic nervous system. But if extrinsic autonomic or humoral, that is hormonal effects, are excluded, it is seen that there is a hierarchy of natural cardiac pacemakers generating impulses at different rates. The sinoatrial node's intrinsic discharge rate is 110 impulses per minute. The atrial myocytes discharge spontaneously at anywhere between 40 to 70, some texts refer to 20 to 60 impulses per minute. The atrioventricular node discharges spontaneously at about 60 impulses per minute. Ventricular Purkinje tissue discharges spontaneously at 40 impulses per minute. A pacemaker focus higher in the hierarchy, termed a dominant focus, always suppresses a pacemaker lower in the hierarchy, which we call a subordinate focus. The subordinate pacemaker foci only appear when some pathological process suppress or destroy the higher dominant pacemaker foci. For example, the AV node subordinate to the sinoatrial node, but dominant to a focus in the ventricular Purkinje tissue. This phenomena of subordinate slower pacemakers appearing or taking over while the higher or dominant pacemakers are suppressed or damaged is referred to as an escape beat if it is a single event, or it is an escape rhythm if it persists. If the impulse originates anywhere within the atrioventricular node, it is described as junctional or nodal. If it is a single early beat, it is a junctional ectopic. If it is a single late beat, it is called a junctional escape beat. And if there are a series of similar beats, it is termed a junctional rhythm. If the sinoatrial node fails to initiate a rhythm, usually the next lowest pacemaker focus, the atrioventricular node, which is a bit faster than the atrial myocytes of 40 beats per minute, takes over at 40 to 60 beats per minute. But the AV node can sometimes jump in at a higher rate. This is nodal rhythm, and the causes of nodal rhythms are those of sinoatrial node failure, such as intrinsic disease, such as coronary artery disease, drug toxicity of beta blockers, calcium channel blockers, or even digoxin toxicity, hypoxia, or excessive parasympathetic activity. Alternatively, the causes may be an abnormality causing a subordinate focus to inappropriately accelerate, such as stimulation of the AV node or the ventricular Purkinje tissues. Once again, intrinsic AV nodal disease can cause this, coronary artery disease, drug effects, or excessive sympathetic activity acting on the AV node. These are all possible causes. Now let's talk about the appearance of AV nodal rhythms and junctional arrhythmias. The occasional junctional ectopic is usually of little significance. For the patient who is established in junctional rhythm at less than 100 beats per minute, however, we must evaluate this arrhythmia carefully. If the rhythm is stable, if QRS morphology is normal, that is, if it's narrow, if peripheral perfusion and blood pressure are satisfactory, then there is no urgency. The patient may soon spontaneously revert to sinus rhythm. But if the rhythm is unstable, that is constantly changing, if the morphology of the QRS is variable, or if there's widening of the QRS, or if peripheral perfusion and blood pressure are compromised, that is, the patient has lost consciousness or exhibits changes in mental state, the patient needs to be treated. Let's consider glycopyrrolate, atropine, isoproterenol, also called in some countries isoprenolone, or artificial pacing. For many arrhythmias, it is unclear whether the commonest mechanism is accelerated automaticity or re-entry, and indeed many rhythms can be due to either mechanism. If the same rhythm appears at a rate greater than 100 beats per minute, it is essentially adult tachycardia with a pulse. If the heart rate is very fast, then you must follow the ACLS adult tachycardia with a pulse protocol, which is presented in detail shortly in a subsequent video. Now let's move on. We will consider idioventricular rhythm. This is a ventricular escape rhythm. It usually occurs in the context of sinoatrial and AV node failure. If P waves are present but unrelated to the QRS complexes, then the diagnosis is not idioventricular rhythm but complete heart block. The ventricular Purkinje tissue pacing focus is the lowest in the pacing hierarchy. The heart rate is often in the 20s to 30s, and its presence indicates serious cardiac disease. The impulse may arise from Purkinje tissue or from damaged ventricular myocytes. Idioventricular rhythm may exhibit a rate in the high 30s, and blood pressure may sometimes be just adequate. However, it is an intrinsically very unstable rhythm. More malignant ventricular arrhythmias or even asystole may be imminent. Further, there is clearly a major problem, so we need to consider myocardial ischemia, myocardial infarction, severe hypoxia, possibly hypercapnia and acidosis, or even hypothermia or profound electrolyte abnormalities. Idioventricular rhythm is often seen when myocardium is dying, such as infarction or end-stage hypoxia. In severe coronary artery disease, the presence of myocardial ischemia or infarction can even cause damaged ventricular myocytes to assume an accelerated rate of depolarization. Very profoundly damaged tissue can behave in very unpredictable ways. An idioventricular rhythm, which is accelerated, is called ventricular tachycardia, which is quite a common arrhythmia during the resuscitation of patients in cardiac arrest. If the ventricular complex has a rate of 40 per minute or less, we call it idioventricular rhythm. If it occurs at 120 beats per minute or more, it is termed ventricular tachycardia. Back to the causes of severe bradycardia. The usual suspects you must consider are sinus bradycardia, junctional bradycardia, idioventricular rhythm, or complete heart block. Advanced Cardiac Life Support has published important guidelines for this situation called adult bradycardia with a pulse. Now, we must discuss our initial response. Your initial response is incredibly important, and it serves as a model for many cardiac emergencies, and it will be similar for many potentially life-threatening arrhythmias. So you must remember this because it has widespread applications. When faced with an adult with an abnormal heart rate, in this case a heart rate less than 50 beats per minute, we need to act. Ensure the patient has an open airway. Put the patient on a cardiac monitor. Choose lead 2, which is best for arrhythmia diagnosis. Administer oxygen and commence an IV or if the patient has a pre-existing IV access, then you absolutely must check that it's functional and then call for a 12-lead EKG. So once again, that was the initial response, and you will do this or a variant on this in many emergency situations, not just for urgent arrhythmias. Now, let's move on. We must assess whether the patient's bradycardia is appropriate. Now, we do this by evaluating perfusion of vital organs. Evaluate for cerebral hypoperfusion. Is there actually altered mental status, or is there even loss of consciousness? Next, evaluate for myocardial hypoperfusion. Is the patient having ischemic chest discomfort or in acute heart failure? Evaluate for generalized systemic tissue hypoperfusion. Is there hypoperfusion? Are there signs of shock? Does the patient look like they're in heart failure? If these are present, the patient is definitely unstable and the bradycardia is inappropriate. If there are no signs of serious hypoperfusion, the patient is stable, at least temporarily, but constant vigilance is required because the patient can go from stability to instability very quickly. If the patient is unstable, we have to intervene to fix it. The initial action is to call for a Zoll multifunction advanced life support device because this can provide transcutaneous pacing or the equivalent. Start pacing as soon as possible. Often, however, there is a delay before the multifunction pacemaker arrives. So while awaiting the arrival of the Zoll pacer, a good temporizing response is to choose a positive chronotropic drug such as atropine 0.5 milligrams IV bolus, and this can be repeated every 3 to 5 minutes to a maximum of 3 milligrams to drive the heart to reach a faster rate. If this does not work, and if transcutaneous pacing is not yet available, consider either a dopamine infusion, but attention to the units here. The dose of dopamine is 2 to 20 mics per kilo per minute, or an epinephrine infusion, which is at 2 to 10 mics per minute. Now note, this is for epinephrine, not mics per kilo per minute, it's mics per minute. And these drugs are slowly titrated upwards until there's a clinical response. That is, a significant increase in the heart rate. By now, the Zoll multifunction device should be available for transcutaneous pacing. This is a very important skill. Successful pacing simultaneously requires both pacing pads on the chest, and you must attach a 3-lead EKG for monitoring. You cannot perform both tasks simultaneously with just chest pads. For emphasis, the pads alone will not pace and monitor the ECG at the same time. This is the single commonest cause of failure to deliver pacing current. Transcutaneous pacing can also fail if there are electrical insulators between the chest pads and the heart, such as fat, water or air, specifically the very obese, in the presence of a left-sided pleural effusion or pericardial effusions or even severe emphysema. In these conditions, where the heart is insulated, we may see total failure of transcutaneous pacing, and so consider emergency transvenous pacing and request an expert cardiological consult STAT. We will continue this discussion of how to save the life of a patient who is in severe bradycardia in the next video. Thank you for watching.